Hello, everyone. I'm Dr. Angela Mattke, and welcome to Ask the Mayo Mom. I'm a pediatrician at Mayo Clinic Children's Center in Rochester, Minnesota, and host of this show about pediatric health topics. Today, we are talking about bone marrow transplant and the use of CAR T cell therapy in children and teens. These treatments are used to treat certain types of cancers. Joining us for this discussion is Dr. Mira Kohorst, a pediatric hematologist oncologist at Mayo Clinic Children's Center. Dr. Kohorst specializes in both BMT and CAR T cell therapy and is the director of the pediatric bone marrow transplantation program at Mayo Clinic Children's Center and the director of pediatric immune effector cell therapy at Mayo Clinic. If you're listening live, remember we really want to hear from you, so please send in your questions and we'll do our best to cover them during our live broadcast today. Dr. Kohorst, thanks so much for joining us again.
Thank you.
This is a really exciting topic. I think you're in one of the kind of forefront areas of medicine, especially in the ways that we're treating cancer in children. And so I'm excited to talk about how you've been able to use bone marrow transplants and this very nebulous sounding thing called CAR T cell therapy as well. So let's start off by talking first about bone marrow transplant. I mentioned in the beginning of the show that bone marrow transplant is used to treat cancer, but I also know that we treat other things besides cancer. So can you share a little bit more about what you typically treat with bone marrow transplant?
Sure. So in general, the bone marrow is the blood factory, so to speak. And so any condition where that bone marrow is depleted or there's little amount of cells, or if it's diseased, are types of conditions that we would use bone marrow transplant for. So in situations where there's not enough cells, those conditions can be inherited, like an inherited bone marrow failure type syndrome, or an immunodeficiency, so your immune system's not working properly. And then also different acquired causes, probably the most notable one that we transplant being aplastic anemia, meaning that there's just not enough cells to produce the blood that you need. And then there's also more acquired causes from the chemotherapy that we give for other cancers. So we can use it for those reasons. And then also when the cells themselves are diseased or not working properly. So that would be, some of the blood cancers we see, like leukemia or lymphoma, can be some different metabolic conditions, so not related to cancer at all, but conditions like Hurler syndrome or a problem with the adrenal glands called adrenoleukodystrophy. Can also be problems with the blood cells themselves called hemoglobinopathies, meaning sickle cell disease or thalassemia. And again, some of the immunodeficiencies that we see in early childhood. So a very broad range of things that we transplant, but I would say that the majority of patients are patients that have pediatric cancers.
Okay. Are there different types of bone marrow transplant that you would use for some of these different conditions?
Yes. So the two main types are a transplant where you actually take the patient's own cells, called an autologous bone marrow transplant, and then you give them back to them later. And the way that this is used most powerfully is in certain kinds of cancers where you have to give very aggressive chemotherapy that would otherwise kind of destroy that blood factory, that bone marrow, kind of irreversibly. And so we can kind of collect those cells ahead of time and then give them back after the chemotherapy as kind of a rescue, so to speak. The other type of transplant that we use is where we take bone marrow cells or stem cells from another patient and give them to our patient to hopefully replace their diseased bone marrow with a healthy bone marrow. And that process is called an allogeneic transplant. And with that type, you can use either the bone marrow cells themselves or stem cells that we can collect from the blood.
Excellent. So, what would be the purpose or the goal of doing the bone marrow transplant?
The main goal is to replace either a diseased bone marrow or to kind of reinstate the normal blood production. And that's true in most of the conditions, but for the pediatric cancers that we treat, there's multiple functions of the transplant. The chemotherapy or conditioning therapy we use to kind of empty out the bone marrow before we give the new bone marrow, that can help treat the cancer itself. And then also, if we're giving new cells to a patient from a different patient, those new cells or that new kind of immune system that comes on board can help provide a long-lasting treatment for the cancer, because one of the functions of the immune system is to get rid of cancers. And so when the cancer has evaded the patient's own immune system, then getting a new immune system might help kind of recognize and attack and kill any new cancer cells that might pop up. So there's multiple goals and functionalities to bone marrow transplant, and it can be a very powerful tool, particularly in different cancers.
Yeah, absolutely. I mean, those are obviously some of the benefits from bone marrow transplant, and
Mm-hmm.
I understand and I've seen that they come with some challenges and sometimes complications. Can you share what some of those would be as you're preparing your families before they're going through this?
Yes, the bone marrow transplant itself is a very powerful tool to treat some of these conditions, and with great power comes great responsibility, I guess is one way to say it. It has a lot of risk involved as well, because we use pretty intensive chemotherapy or radiation therapy to empty out that bone marrow. Those come with different toxic effects. We see problems with infections because the immune system is very low. We also see problems with needing blood transfusions until those new cells start growing in and making blood. We can see different toxicities to any of the organ systems, really. And then with the type of transplant where we take the cells from somebody else and give them to the patient, you can get something called graft versus host disease as well, which is where there's kind of a fighting between the donor cells and the recipient cells that can cause some pretty significant problems. And all that to say, it supportive care and getting patients through this has evolved tremendously over the last couple of decades to where we're able to do it pretty safely now, but it's still definitely a roller coaster and definitely not without a lot of different risks and things that we need to be vigilant for throughout the course.
Okay. You mentioned throughout the course, so this happens
Mhm.
over a period of time. Can you kind of walk us through what that typical course looks like in prep for the bone marrow transplant and then after the bone marrow transplant?
Sure. So first, we have to make sure that the patient is ready to go through such an intense process. And so we do a number of tests and evaluations to be sure that their body is ready. That process can take about a week of evaluations. And then we typically will meet with a patient, review everything, go through a consent process, and admit them to the hospital to start the treatment. The treatment, called the conditioning therapy before the transplant, usually lasts about a week, plus or minus a few days. And then after that, we give the transplant. That takes a few hours. It's a fairly anticlimactic procedure, kind of like a blood transfusion almost. And then the real waiting period is from when we give that transplant until those new cells start to grow in. That process can take anywhere from 2 to 4 weeks for those new cells to grow in. And we keep the patients in the hospital for that whole time, given the pretty significant risks for infections and other complications that can come up. So the whole time in the hospital, from the start of the treatment until they're able to go out of the hospital, is usually around 4 to 8 weeks, depending on the complications that might come up. And then we also will keep them pretty close by to our campus here in Rochester up to that first kind of 100 days after the transplant. And so for patients that are traveling from, a distance, we usually try to set them up with housing close by so that, we can keep close vigilance. And if there's any problems that come up, they're kind of very close to healthcare to get the services they need quickly. So it's a long process, and we try to be very upfront with people from the get-go, since it can really uproot people's lives for that time period, and folks need to plan for that.
Okay. So one of the most important things is that we're going to talk about today, I think, is the call to action to us as a community. So what can we as a community do to help these kids that are in need of bone marrow transplant?
I think that the two most important things that we can do for these patients is donate blood or platelets. These kids need lots of transfusions, and so any help we can get boosting up our blood bank would be very helpful. And then even more unique to this population would be to sign up for something called Be the Match. That's where you could be a potential bone marrow donor or stem cell donor for these patients. And we have thousands upon thousands of people in this registry, but even still, we sometimes can't find a good match in the registry. So we try to be very proactive about encouraging our community members to sign up for this, because you really could save a life. And I think it's a very meaningful thing for donors to do.
Absolutely. Well, let's move on to talking about the CAR T therapy. What is CAR T cell therapy? Can you describe it a little bit more, other than me using the acronyms, because I don't
Yeah.
really understand it that well?
Sure. So CAR stands for chimeric antigen receptor, which is probably equally as nebulous. So I'll stick to calling it as CAR T. But it's essentially this very new and powerful technology that we have, where we collect T cells, or kind of immune cells, from the patient themselves, and we send them to a lab to get re-engineered to help directly fight that specific kind of cancer. And then the cells get shipped back to us, and we give them back to the patient. So with that, they're the patient's own cells, so it's a little bit less risk for things like the graft versus host problem that we've talked about. And because they have a very specific target, the kind of toxicity or long-term effects can be reduced with this method. And we're using it pretty effectively now, and for the last 10 years or so, in patients with leukemia and lymphoma, but certainly many other types of cancers are working towards utilizing this modality as well.
That's really exciting. In kids, when do you use the CAR T?
Mm-hmm.
Is it something you would go to right away, or would you start with kind of more conventional, like chemotherapy
Mm-hmm.
or radiation, depending on what type of cancer you're treating?
So currently for children, the main time that we use CAR T cell therapy is in those that have very tricky leukemia. So leukemia that doesn't respond to initial treatment very well, or that might respond but comes back. So we would consider those to be relatively high-risk leukemia. And it's a specific kind of leukemia that we're able to use this treatment for called B-cell acute lymphoblastic leukemia. And this is the most common type of leukemia in children, but still not the only type. So particularly where I'm using this the most is in those patients with relapsed or refractory B-cell leukemia. Although we definitely as a community are trying to find out ways in which we can use this earlier in treatment to help reduce some of those kind of long-term effects that we talked about. But it's using it earlier in therapy is still under investigation.
Okay. You mentioned that there might be maybe less side effects, but I imagine
Mhm.
that it still comes with its own host of side effects and potential complications. Can you share a little bit what those might be?
Yes, so there's some unique toxicities to CAR T cell therapy that we've encountered and have learned how to counteract. One of those side effects is something called cytokine release syndrome, and that's a problem where children can have fevers, low blood pressure, or low oxygen levels, or a combination of those three. And we've learned over time how to treat this very effectively, and tends to be something that as long as we address it early, we can get on top of it very well. The other type of problem that we can uniquely see in CAR T cell therapy is neurotoxicity, or kind of some changes to cognition, which are very transient, meaning short-lived. And again, we have certain treatments we use to help when this particular complication comes about. Now, those two side effects, so the cytokine release syndrome and the neurologic toxicities, typically come up in the first week or so after CAR T, and rarely will last beyond a couple of weeks. And I would say in the clinical trials where we have this data available, no patients have this beyond kind of a 4-week period. So although they can be very severe and life-threatening, they're typically short-lived. And as a community, we've learned how to treat these and overcome them pretty well. And so it's something that we have a lot more confidence in managing as time has gone on and as we've all developed more experience with these new treatments.
It, what do you know about how effective the CAR T cell therapy is,
Mhm.
just compared to kind of other cancer or other treatments as well?
Yeah. So in that particular population that I was talking about with this B-cell acute lymphoblastic leukemia, for those that have disease that doesn't go away with standard treatment or comes back despite our best efforts, historically those patients had survival rates of probably less than 20%. With CAR T, we've been able to cure about 50% of those patients, but still about 50% will experience a disease recurrence after the treatment. And so the biggest goal in the field right now is to try to determine that 50% so that we know who we need to give more aggressive treatment to after the CAR T cell therapy and who we can safely monitor. So it's certainly not a cure-all, but it's doing a better job than just about anything in the last 100 years of treatment in this particular area.
That's very exciting.
Still a long way to go.
Yeah, yeah. What other is on the horizon in regards to for cancer treatment and or the use of CAR T cell therapies?
We're certainly trying to optimize this therapy for leukemia itself, and
Hmm.
there's a lot of different strategies to do that. But I think the most exciting area is in using this treatment for other kinds of cancers as well, be it other types of leukemia that we've not been able to totally figure out yet, or be it solid tumors or brain tumors. It's a very exciting type of treatment that, like I mentioned, has little downside. So to be able to use it in some other areas, I think is very exciting. In pediatrics specifically, we're starting to use it more in things like neuroblastoma or brain tumors. That's still fairly experimental, and certainly, again, is not something that's curing all patients. But we're seeing some effectiveness in those particular areas right now. On the adult side, there's a lot more excitement and growth in the lymphoma realm, as well as in multiple myeloma. And it's really changing the landscape in those areas for our adult colleagues very rapidly. And I'm sure that we'll see some further advancements in our other pediatric types of cancers as well.
I feel like when I was in training, this was something that was like wasn't seen very much. But
Mm-hmm.
I'm old now, and like you said, this has been pretty commonplace being used for at least the past 10 years. So it's very exciting to see how far
Yeah.
cancer treatment has come in even just such a short time. So
Yes. Now, in the first pediatric patient that was treated with CAR T cell therapy is now a 10-year survivor. So we've been doing it for about 10 years.
wow,
That being said, it's only been commercially available for about the last 5 years.
yeah,
But I will say it's one of our pediatric claims to fame in that this was a product that was first approved in pediatrics,
hmm,
and the adult approval came a little bit after. So we feel very proud of this major scientific advancement.
absolutely. Well, we've reached the end of our time. Thank you so much for everything you've shared. I just want to give you an opportunity if there's any parting thoughts or any other things that you'd like to advocate for.
No, I think we've covered a lot of ground, and again, I think the most important thing that viewers could do is to consider becoming a bone marrow donor or a blood donor. And just if you have a family member or a friend or if your children have a classmate that has a pediatric cancer, just learning to offer as much help as you can to these families that are going through so much, and just trying to be understanding and supportive and helping them walk through that together. I know that they appreciate all the support that they can get.
Absolutely. Thank you so much, Dr. Kohorst, for joining us today. And thank you, everyone who listened. Have a wonderful day and stay safe this summer.